NHS staff are actually in contact with more than 1.5 million patients and their families every single day. The funding for the NHS will be increasing now in real terms, but in 5 years' time, the net increase will be less than 0.5%. So actually big productivity savings are going to be needed if a funding gap is to be avoided. Some are predicting it actually could run into several billion pounds. The NHS has been asked to cut management costs by more than 45% over the next 4 years. And the TUC recently gave controversial estimates of thousands of NHS jobs cuts, including doctors, including nurses. Now, I'd like to turn to Ian Cumming, you're Chief Executive of the outgoing NHS West Midlands. It can't be easy being in charge of an organisation that's effectively being closed down. How can the impact of these changes to the NHS be seen on the workforce as anything less than negative? How can you make it seem positive?
Well, it's not about making it seem positive, it's about making it positive. I mean, first of all, what this is absolutely not about is how do we make our existing workforce work harder. There's very little opportunities, very little slack in the system at the moment. I'm not saying there's none, but there's very little slack. This is about how do we work differently. It's an old cliche, isn't it? But how do we work smarter to actually deliver healthcare in a different way? Let me give you an example. There's one hospital in the West Midlands that is now undertaking a significant percentage of its elective hip replacements with a 23-hour length of stay for the patients. The average length of stay across the West Midlands is about 4 days for that hip procedure. Now, not only is that a shorter length of stay, which clearly is more efficient in terms of the utilisation of the hospital beds, but actually the patients like it more, clinical outcomes are as good, and it's somewhere in the region of £500 per patient cheaper than what we're doing at the moment. So that's the sort of technique that we need to be putting into place. We need to be redesigning systems. We've already heard that we need to stop admitting patients to hospital with chronic conditions simply because perhaps we haven't had the resources in the community to manage those chronic conditions in a better way. So it's about redesigning pathways, redesigning how we deliver healthcare, not simply getting the whip out and saying to everybody, harder, 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 because that will fail.
Jenny, do you feel the chill wind of cuts? Obviously, you used to work as a nurse and you're now looking after the voice of patients. Are they worried about these cuts?
I think they're dramatically worried about the cuts. I think that's all they hear about. And obviously, it's not just the NHS, but definitely with the NHS. And also, I've still got a lot of friends who are nurses and you know, in hospitals, especially sort of in the lower grades of nurses, they're very worried about what's happening. I'm very, very worried. And I think it's getting worse. And I think people's morale is getting worse. And it's very hard to be positive when you think, you know, I've got a mortgage at home and, you know, how am I going to pay for it next week?
Sue, is this something you agree with?
I completely agree with Jenny. I think it's very difficult to pretend that the morale of staff in the NHS has not been hugely affected by what we're seeing at the moment. And that is partly about cuts, but it is also, I'm afraid, partly about some of the rhetoric that has been very negative about the role that people like Ian have played, for instance. I'm not talking about the scaremongering, I'm talking about some of the demonisation of the people who are doing the back office work. Ian was talking about productivity, and we're looking at hugely increasing the productivity of our clinics. That means you've got to chase up people to remind them of their clinic times, and if people say they can't come, that you have somebody who can then chase somebody else on a waiting list to say, can you come in? Now, we don't want nurses doing that. We need clerks and administrators doing that. You can't run a system like a huge hospital or something, you know, of the NHS as a whole without really good managers. And I'm desperately worried that some of the demonisation of managerial staff is going to cause, absolutely, and people will leave because they see their work undervalued.
Now, Dr. Coward, clinicians are going to be running multi-billion-pound commissioning organisations. Now, the jobs that people do in a typical GP surgery at the moment, when all that's being scaled up and they're part of a consortium, do you think their jobs are actually dramatically going to change?
No, I don't think so at all. I mean, GP commissioning will happen on a number of tiers. So, for example, there are about 100 GPs. It's not just about GPs, by the way, it's about the primary care team. But if you just look at GPs for a moment, about 100 GPs in our consortium serving about 150,000 patients. Now, the way we're designing it at the moment is that on the board, the lead GP will probably work 3 days a week. The 2 vice chairs will work a day each a week in the consortium, and then we'll have various clinical directors working a half day a week. So for the vast majority of GPs, their working life won't change at all. It will only change in this, that we will have to be more accountable for the commissioning decisions that we make. I said earlier that GPs commission 80% of NHS services, and there's no doubt going forward we're going to have to justify our use of those precious resource. So for the majority of GPs, their working life will not change, except they will have to consider and take more responsibility for the budgets that they're asked to come in budget on.
Now, there are going to be big changes, though, aren't there, in the way that there's sort of £5 billion a year training budget for NHS staff is spent. Now, the government, I understand, wants to end what is called top-down workforce planning. I hate these phrases. They're going to end top-down workforce planning to respond to the bottom-up changes taking place. So sort of cut through the jargon. What do you think this is going to mean for the way that doctors, the way that nurses and all kinds of other healthcare professionals are trained in?
Okay. Well, in the West Midlands at the moment, the responsibility for much of the oversight, effectively, of the workforce rests with the Strategic Health Authority in terms of the education and training function. And Dr. Liz Hughes is in the audience tonight, takes a key role in that, particularly with regard to the medical workforce. The proposals that are coming forward is that this is actually a responsibility that's taken on to a much greater extent out in the system, so that the providers of healthcare have a much greater say in the education contracts that are let and the way in which education is delivered in the system in the future than perhaps we have at the moment.
Can I put this actually to Dr. Liz Hughes? The skills networks that I've heard the phrase used of employers have been suggested as the way forward. What does this mean? And do you think that it will mean that the next generation of healthcare providers are going to be trained differently?
Well, I think what we have to understand that whilst we have the white paper that's talked about GP commissioning, we're currently in a consultation period around the workforce part of that sort of health revolution. So I think I think we've got a great opportunity with the Clinical Skills Network to promote multi-professional working. I mean, the West Midlands, we've been in the forefront of doing that, and we've been actually we are an integrated workforce deanery currently, and actually have been foremost in promoting new roles so that we can actually improve the healthcare, the care pathways that we deliver by just not using traditional means, so very doctor-centred, as we've heard before. So I think that clinical skills networks, which are a concept at the moment, we haven't really understood how they might deliver, a very good opportunity for this multi-professional workforce to be trained, to actually, for all professions to learn together. One of the things we have to be careful about is that, we're trying to bring together a great deal of professions that actually have very different regulatory frameworks around the training. And we need to ensure that we actually continue to train at the levels we need to for each of those professions. So we're responsible for over 5,000 junior doctors, for example, whose training programs might be up to 9-10 years. So in any transition period, we have to maintain all the training of those doctors. It needs to be a slow transition, because we actually have to maintain that quality training for not only medical staff but for all of the other professions that we commission for, to make sure that there's no great dip in the quality of their training.
Are you optimistic that there won't be that dip?
Well, I think we have to manage the transition carefully, and part of the consultation period that we're in at the moment is to put forward our views as to how that might occur and the safeguards that we need to put in place. And that actually, once the consultation is completed, then we hope that those concerns and also positive suggestions will be pulled together into, to make this a very positive outcome and actually sort of an innovative, sort of cutting-edge way of training all sorts of staff.
Can I ask Leanne Brooks from Unison, what does the future hold for your members in the NHS workforce with all these changes happening?
Well, first of all, I have to disagree with Ian, because when he says we don't need to work harder, I spend a lot of my time at the moment doing reorganisations, management of change and redundancies, unfortunately, and also vacancy freezes. So when somebody leaves or somebody's made redundant, that post is not filled. So the staff that are already down to the wire, you said so yourself, there's no slack in the system, have to take up that. So the issue about not working harder, for me, doesn't ring true, I'm afraid, and I'm sorry. That results in the staff becoming very stressed and exhausted. It results in the fact that they're having to stay over the shifts because there's no slack in the system. If somebody goes off sick or if somebody goes on maternity leave, that position is never backfilled. The staff are having to pick that up. There's also the issue around, succession planning. And what about the future? There's a high proportion of nurses, midwives and clinical staff that, are coming up to retirement. There's a high proportion. And what are we doing to address that? Because, if they all retire at once, we're going to have a big gap, which is going to put even more stress on these staff. And what I am seeing now from our members and staff in all of the trusts in the West Midlands that I go to, which is every single one, they're all stressed. They're all working a lot harder. They're all being phoned up to come and do extra shifts. They're all being asked to stay over. And it's not an issue of lacking motivation. It is an issue of low morale. There is a low morale because of that reason.
Can I ask you, Sue Davis, what do you think of what Leanne is saying about this dip in morale, not working smarter but working tireder? What do you think of that?
I think it's a big worry. I was on one of our cardiology wards this morning talking to the matron there, and that was exactly what she described, an anxiety about how the cuts would affect staffing. And although my trust is not planning cuts in nursing staff, that anxiety is there within the wards, and they are all feeling that there's great pressure on them and great pressure on all their staff. So I think the anxiety is very real.
Professor Gupta, can I ask you, you're involved in the education of doctors at the Birmingham Women's Hospital. Are you looking forward to having more control over the way that training budgets are spent?
No, I think that we should leave that to, not as clinicians, we should leave that to the clinical tutors and those actually employed or have the expertise in that. We should be looking at, from my perspective as a consultant in the hospital, is to actually train them specifically in the skills that they want to acquire, as opposed to the training from a wider perspective. So that would be where Liz comes in to do that sort of aspects, but we do the sort of more specialised area of the training specifically.
Paul?
Yeah, I think there's some really key issues here, and one for me starting point is that the white paper, we're talking about two things here at the moment. We're talking about the cuts and we're talking about the white paper. So there are a huge amount of pressures in the system around the £20 billion that has to come out, and I think that's colouring some of the stuff around the huge changes going on at the moment and the pace of change that's going on.
The argument that we're hearing is that the changes and the transformation and the working smarter, whatever phrases one used to describe it, will balance the need to reduce spending. And
they won't. I think that's the point. I think, and for me, one of the big issues is that the white paper is very much focusing on GPs. And actually, Ian himself said earlier, actually, it's about a multi-professional approach. We should all be working on this. And for me, there's a big gap in the paper at the moment around where is the nursing voice. Now, GPs themselves will tell you that nurses, when the Quality and Outcomes Framework was introduced in general practice, it is nurses and healthcare assistants who deliver most of that in terms of the meeting that. Some of the anxiety around the education and training for me is, and I have to say, there are some fantastic GPs there, but there are really worrying examples where because of cost, healthcare assistants are being used, for example, to undertake cervical smears in general practice. Now that, in my opinion, and the opinion of the Royal College of Nursing, is inappropriate. So there's a real challenge there, and we're already seeing it before we get to GP commissioning. I am hearing in our region, in the West Midlands, there are GP consortia members who do not understand the role of the specialist nurse. And actually, rheumatology nurses, for example, we've had that example today, have made the most enormous impact in terms of care. And I think the worrying thing for me is just one more point around Andrew Langsley himself has said, we know that a third of these consortia are going to do really well. A third will do it okay, and a third will fail. And one of the biggest anxiety among our members is, what happens to the third that fail? There will be organisations going out of business. There will be people losing jobs, hand over fist potentially, in terms of this whole, back to the concept of any willing provider. And it puts us in a difficult place.
Let me put that to Dr. Coward. Do you think there are GPs who don't understand the role of specialist nurses?
I can't speak for all GPs, I can only speak for my consortium. GPs absolutely depend on their healthcare assistants and practice nurses. Now, as an example of that, on our integrated care consortium, we have a nurse on our board, Marie Henson. So we are committed. I've already referred to the primary healthcare team. So the view of our consortium is this is not GP-led, this is general practice-led, and the practice nurses are crucial. But I would like to mildly challenge you on a clinical governance point. As far as I'm aware, it is absolutely against all clinical governance rules for a healthcare assistant to take a cervical smear, just as it would be for them to perform childhood immunisations.
Can I ask John Wilkinson, Dr. John Wilkinson, another GP, do you understand with your colleagues the role of the specialist nurse?
Yes, I think we use rheumatology nurse advice quite a lot. We've got heart failure nurses, we've got COPD nurses all in the community, and they're a great. They've actually changed the management very much for the better for these chronic conditions. So yeah, I think we use them very well, and I think they've got a very important place to play, both now and in the future.
Liz, can I just ask you to sum up where training is going? Because, as you said, we've got this kind of two-speed thing that this expert training takes a long time to deliver, and yet we've got this very rapid pace of change happening at the same time. So how are you and your colleagues managing this?
Well, I think what we have to do is we need to deliver safe and competent healthcare professionals, be it nurses, allied healthcare professionals, or in fact doctors. And we have to work within the framework of the curriculum that have been set down in order for us to achieve that. What we have to do is, and we've got a very flexible structure, and we have 12 postgraduate schools which are joint with the colleges, so we're able to put into place fairly immediately new things that come into play that we have to train on. So if there are updates to the curriculum or changes that occur, then we're able to immediately put them into position for the trainees already in training, as well as the people coming in. And we are going to have to improve that flexibility in order to be able to deliver the training changes that we can't even think about at the moment, which will be for the technology that we can't have, that we don't even know about. So that's very key. And so, the way we go forward will be different from the way we've been in the past. Using things, again, like simulation, using a lot of different technology so that trainees are able to practice and get competent before actually doing it for real, as it were. And I think that's very important.
Can I put this to Francis Carter now? You're at the beginning, aren't you, of your nursing career? You're entering, I suppose, the profession at probably the most dramatic period of change, although I know that everybody knows that change has always been happening in the NHS. Are you running for the hills, or are you actually quite excited about what you're hearing?
I actually qualify in April, and I'm lucky in the fact I've got a job down in Portsmouth because I'm in the military. But I've got friends who are, they've done 3 years of hard graft in the course, and they're worrying about, some of them have got jobs, other ones haven't, and some of them have got jobs but only for a limited, like a 12-month sort of term. And they're obviously mortgages, childcare, they're very apprehensive about what's going to happen. And you can see it on the wards, there's sickness and stress, and you get in the morning and you find there's empty spaces on the boards where there should be names, and that just adds to everybody's sort of stress during the day, and it's going to be interesting, I think.
Are you positive about what people are trying to achieve?
To be honest, I wasn't quite sure what the whole thing was about, and I've learnt an awful lot tonight by doing this. But and a lot of the nurses on the ward today, I was going, "What do you know?" And they were like, "It's to do with GPs having budgets." I don't think they're knowing about possible job cuts and things like that. So I think it's going to be interesting to see what happens in the different trusts and how the nurses are perceived and how
you're used.
Yes,
Dr. Hughes. Again, your first year of foundation, junior doctor. we live in interesting times, don't we? How do you feel that your career is going to pan out? Are you excited about these opportunities?
I think perhaps this is the time we could use the word scared. I do feel quite apprehensive about the training that we're going to receive, and I'm worried about the quality and that it's going to be continually regulated, and also how long these changes are going to last for. When will the next changes happen and what will they mean? So I'm quite anxious from that point of view, and obviously anxious as well about the availability of jobs and training posts that are available in the future. So yeah, it's quite apprehensive times.
Just leave you the last word. Do you actually feel there's a need for anxiety? Or actually do you think that, you know, these young people should feel confident that training will be there to support them?
I think that doctors coming into training should not feel anxious. I think, you know, we understand the absolute necessity to have skilled healthcare professionals. We may train in a different way. We may find that we have to organise in a different way, but we will always need those skilled healthcare professionals to deliver safe and competent care.
Liz, thank you very much. Now, ladies and gentlemen, that really brings us to an end for tonight's NHS Local discussion. Many, many thanks to all of you for your contribution and for your insights. The roadmap for the future, as we know, is in place, but the devil will be in the detail, and we've had a lot of detail tonight. NHS Local is going to be there keeping you up to speed, keeping you informed with these changes as they take place. But for now, it's goodbye from Queen Elizabeth Hospital in Birmingham. Thank you.